the sort of the more usual type of ASCO data of prospective randomized clinical trials, the first of which will be presented by Dr. Christopher Sweeney, the medical oncologist at the Lank Center for Genitourinary Oncology at Dana-Farber Cancer Institute in Boston. He will present the findings from a randomized phase 3 trial evaluating the impact of adding enzalutamide to standard initial treatment for metastatic hormone-sensitive prostate cancer. Dr.
First of all, thank you very much to ASCO for giving us the opportunity to present these results, and also for everyone making their time this morning to come and hear the results. First of all, I'd like to just emphasize that this trial called ENZUP is an academic global collaborative trial, and there are some differences from this study that was presented on Friday with a similar drug, apalutamide. One is that this is academic, and there are some differences in the designs that come from it being an academic study where we had some more flexibility to respond to the changes in treatment that were occurring. I'd also like to say that this is a wonderful collaboration between the Clinical Trials Centre based in Australia, Cancer Trials, Canadian Cancer Trials Group, CCTG, Cancer Trials Ireland, and the Dana-Farber Cancer Institute, and it was led by a new cooperative group out of Australia called ANZUP. I'm an ANZUP member as well, but based in Boston, and I had the huge honor of presenting the results on behalf of Ian Davis, study co-chair, who's with us, and the co-authors. That went the wrong way. This goes the right way. By way of background, until 2014, testosterone suppression, plus or minus the standard anti-androgens, was the only therapy. We knew patients with a higher burden of disease had a shorter overall survival, and that was the state of affairs for about 70 years. Improvements in outcome for hormone-sensitive prostate cancer emerged with the use of agents that were active in castration-resistant disease when cancers were growing with a low testosterone. With agents like docetaxel, in 2014, we presented the results of the Charted study then, and in 2017, we learned about the results of a hormone, abiraterone, that also improved the survival of men when used in the hormone-sensitive setting. Enzalutamide is a potent direct androgen receptor inhibitor, so another type of hormonal therapy. Again, it's been shown to work in men with castration-resistant disease, namely disease growing despite a low testosterone. At GU ASCO, we learned that enzalutamide delayed the time to progression as measured by changes on scans, and this study allowed patients to have had prior docetaxel based on the Charted data. The study was called Arches. Janssen Pharmaceutical Company had the results presented at ASCO on Friday of apalutamide, showing that it prolonged progression-free survival and overall survival, and again, it allowed prior docetaxel. ENZAMET is the first trial to present the overall survival results of enzalutamide plus testosterone suppression and the outcomes if patients also received concurrent docetaxel. And there's the key difference that I want to highlight. The design was quite simple. It was testosterone suppression alone with the non-steroidal. So the other differentiating factor is that we actually put in the weaker anti-androgens, which were the standard, not a placebo, but the actual standard of care, which has some activity, and compared that to testosterone suppression plus full dose, more potent androgen receptor inhibition. We stratified patients by their volume of disease, good prognosis versus poorer prognosis, planned use of the early docetaxel concurrent with the enzalutamide, performance status, and use of agents like denosumab and zoledronic acid, and how fit a patient was, their comorbidity scores. Notably, the patient population was representative of prostate cancer in terms of age, 69 years. Notably, this was a global study with most of the accrual coming out of Australia and New Zealand with 60% of patients, Canada with about 20%, the UK and Ireland of about 17%, and the United States is represented by just one institution, Dana-Farber, at about 4%. Notably, we had about 45% of patients receive concurrent docetaxel, which differentiates itself greatly in terms of not only being concurrent, but the frequency of use of docetaxel, recognizing that some patients' standard of care is testosterone suppression alone, and about half the patients, testosterone suppression with the docetaxel is the standard of care, depending on a patient's chemofitness and how much cancer they have in their prognosis. We also note that half the patients had a poor prognosis with a greater burden of metastases, namely 4 or more bony metastases, visceral metastases, is what high volume is defined as. The highlight is that we actually saw at the first interim analysis, so this is the first look, and we were told to report the results early because there was a survival benefit already seen after half the information was received. The first thing to note is that there was a 33% decrease in the rate of death, the hazard ratio of 0.67. It was statistically significant at the level to say that we should report the results at the interim analysis, so it was a very stable result. But in absolute terms, for the overall group, it meant that there was an increase of percentage of patients alive at 3 years, is an easier way to reference this, going from 72% to 80%. What we did note also is that the therapy significantly delayed the time to PSA rise on therapy or clinical progression or death. And then when we took out the variable of PSA rise, we noted that there was also a longer time to clinical progression independent of the blood test, namely worsening changes on images, symptoms, or signs that the patients experience from their progressive cancer. Both of them had a hazard ratio of about 0.39.4, meaning there was a 60% decreased rate of progression at any one time. When we broke this study out, and this is where the long conversation is going to be, we saw that when docetaxel was added to the testosterone suppression, there was again a significant improvement in the, or delay in the time to progression, as seen in the top left curve, but the top right curve, we actually do not see a significant treatment effect on overall survival at this early analysis, with a hazard ratio of 0.9, and it was, so that's the first information that we as the investigators will have to think through of what treatment to give our patients if they've had docetaxel. However, 2 things. Most of those patients who got docetaxel had the high volume, were the poor prognosis patients who do benefit from the early docetaxel. On the other hand, men who did not have the docetaxel, there was a significant delay in the time to progression again with a hazard ratio of about 0.66, 66% decreased rate of progression, but the overall survival benefit was quite marked with a 47% decreased rate of death in those patients. Mostly, these patients were the low volume, good prognosis patients who we have not seen benefit from the early docetaxel. Side effects is a very real factor when we compare not only the treatment benefit, but what is the cost in terms of adverse events. Enzalutamide has got some associated fatigue, hypertension, and some men have some frailty in the 5% range, which may have them have some falls and be a little bit frail. And we as physicians have to say, are the patients fit enough, even for the hormone enzalutamide? And there are some side effects and concentration impairment that we need to be counseling our patients about the risks. So the overall conclusion is early enzalutamide substantially improved the time to progression and overall survival when added to testosterone hormone, standard metastatic hormone-sensitive therapy, be it testosterone suppression alone or with docetaxel. The clinical interpretation is enzalutamide added to testosterone suppression represents an appropriate option for men with metastatic prostate cancer commencing testosterone suppression. The benefit is clear in both low and high volume patients, which distinguishes what we know with docetaxel. There is a delay in progression with an improvement in overall survival, but there is toxicity. And what I didn't show here, but will show in the presentation, is that the enzalutamide actually increased the docetaxel-related toxicity that needs to be reconciled. We do plan to do quality of life analyses, and we may actually see that there's a benefit from adding the enzalutamide to the docetaxel if there's a meaningful quality of life improvement, or longer follow-up actually shows that there's improved survival over 3 years. And I thank everyone for their attention and highlight again this wonderful academic global collaboration that I had the honor to be a part of. Thank you for your attention.
Okay, thanks, Chris. So I'm going to ask ASCO expert Dr. Niresh Agarwal to provide some additional context. There's been a lot of advances in the treatment of prostate cancer in recent years. It's always complicated to figure out where to place some new data. So Dr. Agarwal, can you clear it all up for us?
Yes. So advanced prostate cancer is the second most common cause of cancer-related deaths in American men. The current treatment options for men with newly diagnosed advanced prostate cancer include chemotherapy, as Dr. Sweeney mentioned, or an oral pill, abiraterone, which require concomitant use of steroids for many years. What we saw in this study is that enzalutamide, or Enza, to make it simple, an oral pill, which is a novel class of drugs for these men, and targets AR, androgen receptor, a protein which is critical for disease progression in these patients. So targeting AR with enzalutamide improved the overall survival in a very remarkable fashion. Remarkably, the disease-free survival were also delayed. So what are the implications of this study? Or how do we analyze the findings in a simple perspective? In my view, using enzalutamide early on will allow our patients to avoid chemotherapy and steroids for many years, thus hopefully improve their quality of life. And of course, one positive study is encouraging, but two large studies, as Dr. Sweeney mentioned again, demonstrating similar findings is even better. In this meeting, we saw the data for apalutamide, a similar drug with an equally impressive margin of benefit. This increases my confidence that targeting AR, this protein, is the optimal approach for newly diagnosed patients with advanced prostate cancer. Thank you.
Great. Thank you so much.